interested in is eventually working with LGBTQ plus adolescents and their families.
Thank you for that reading. So today we're going to talk about the Wpath standards of care. And this, so in talking about the standards of care and talking about these various things that are included when we're looking at letter writing, when we have folks that come in who are seeking letters, these are just going to be some general things to think about in terms of you as a provider when you have folks like that coming in. So for those of you who don't know, Wpath stands for the World Professional Association for Transgender Health. And so the idea behind the standards of care is that folks who are, we have trans folks that are getting the same standard of care across the board. Unfortunately, that is still not happening, which is why the standards of care are in place. But the idea is that folks who are part of the trans community and gender nonconforming individuals have those safe resources in providers when they're seeking services. So gender care itself is not just limited to mental health care. Gender care can look like primary care. It can look like gynecological care or urological care. It also includes preserving reproductive options, especially because, you know, the folks that are birthing persons now aren't just mothers. We are having folks from all over the spectrum of gender identity who are becoming parents. So reproductive options and reproductive care is an essential part of the standards of care. We also have things like voice therapy, obviously us as mental health care professionals, and then the hormonal and surgical options that are available. So the idea behind the standards of care is that they're supposed to be flexible, but that we have a sort of set standard for the treatment of gender dysphoria. We as mental health care professionals, we have the ability to modify our mental health care to our individual client, and generally speaking, the same goes for providers across the board. Ultimately, having client-centered care or consumer-centered care is about tailoring treatment to that particular individual. And the Wpath standards are really, they emphasize the importance of that. So when we're looking at gender dysphoria, we're looking at that significant distress that is caused when a person has that discrepancy between their assigned gender or their assigned sex at birth and what their true gender identity is. So there's a, there's a distinct difference. We're not talking about tomboys or things like that. We're talking about extreme distress. We are talking about a distress, almost even a disgust, I would say, with that assigned sex at birth and that misalignment with a person's gender identity. So the Wpath standards of care break down treatment options between children and adolescents with gender dysphoria and then adults with gender dysphoria as well. So when we're looking at gender dysphoria in children, we are looking for clothing preference, we're looking at toy preference. However, that doesn't mean that every child who is interested or engaged in the opposites or toys that are perceived to be of that child's assigned sex means that they're experiencing gender dysphoria. You know, I have a 6-month-old child who was assigned female at birth, and oftentimes I dress her in gender neutral clothing or boys clothing. And if she wants to dress that way when she's gets older, that she absolutely has that ability to do so. It doesn't always mean that that person is going to experience gender dysphoria or that she might experience gender dysphoria. But those are some things that we're looking at when we're looking at gender dysphoria in children. There's also that character or that key significant factor there is that we're looking at the unhappiness with their sex characteristics and their desire to be of the opposite sex. And since there is that misalignment with their assigned sex at birth and their gender identity, oftentimes kiddos struggle with other things like acting out behavior, anxiety, and depression as well. So in adolescence, we're looking for this, not necessarily toys, but we're looking still at the same or similar characteristics. So having a strong desire, as well as having that strong desire for hormones or to undergo gender confirmation surgery. And we also have those we also have those co-occurring disorders as well. So there's defiant behavior, there's anxiety, there's depression. Those are just a few things that can be experienced, but there is oftentimes a co-occurrence with something else going on. So our role as mental health care providers is to first and foremost assess for gender dysphoria. And I would say, generally speaking, I know as myself as a practitioner, I have a certain way, a certain style about myself that I adhere to when I am assessing someone, not just for gender dysphoria, but for any mental health diagnosis. So we're looking at that we're looking to assess that in our client. We're also part of our role as not just providers, but also as advocates, is to provide some psychoeducation and support towards the kiddo's family, especially if their parents have a lot of questions. Excuse me, we can be in a role that can be a really significant role or really impactful role for how parents might perceive what that child is experiencing. So yeah, in terms of our other roles, we're also looking to assess the other coexisting mental health problems that are going on, making sure that we're also referring for those physical interventions. And I'll say too, that not just referring for physical interventions, but making sure that we're doing our part, again, as advocates, to refer to other providers who are going to provide that gender confirmation. I know, again, I'll use myself as an example. When I've worked with folks in the past, I live close to the Pittsburgh region. And so I know there are certain there are certain providers in the Pittsburgh area that if I refer, especially if I refer children to them, those children aren't going to be met with invalidation. They're going to be met with the same sort of supportive care that I'm attempting to provide to them as a clinician. So making sure that you are referring to other providers that are upholding the same things is important. But also in that documentation, you need to make sure that you're documenting that gender dysphoria is part of the referral as well. Again, the psychoeducation piece and referring for peer support can also be a really impactful thing that you can do for your client or consumer, because I think not just with trans care, but also within the spectrum of mental health care in general, it can feel so isolating. And when we have peer support for those kiddos, and we have peer support for parents as well, there is less, I don't want to say less concern per se, but there's less likelihood that that kiddo might be feeling alone or feeling like that whatever they're going through, they're the only person that's going through whatever they're going through. So peer support can be a big impactful piece as well. So when it comes to assessment, as clinicians, we don't want to be invalidating or dismissive. It is not our place, and we excuse me, we should know this as providers. It is not our place to make clients' decisions for them. It's not our place to try to talk somebody out of something. It's our place to provide a safe, empathic space for that client to express what's going on with them, express what it is they're feeling and what it is they're experiencing. And we aren't being invalidating or dismissive in that space. So first and foremost, when assessing for gender dysphoria, it's important that we're not dismissive. It's also important, again, going back to that advocacy piece, that we're educating the client, we're educating the client's family, and that we can really be in a role we can be part of a role to help parents sort of become more accepting, break this down a little bit for themselves, and can maybe break down a wall, excuse me, break down a wall that might be there between that client and their parents. So we also want to explore the nature of that child's gender identity, making sure that we're looking at emotional functioning, peer relationships, intellectual functioning, things that we would normally look for in any sort of psychological assessment or evaluation. And on top of looking at the family function within the family unit. When you're assessing adolescents, it's also important to make sure that you're including information regarding treatment options. And you may, depending upon what kind of relationship you have with that adolescent client, you may be able to see or maybe able to have a dialogue with that client about the reality of medical intervention when it comes to gender confirming surgery or transition, and so on and so forth. So when looking at psychological and social interventions, again, we're going back to looking at helping families come to a level of acceptance if they're not there. We're also looking at helping to reduce the distress of those other mental health diagnoses or mental health conditions that they're experiencing. And the family is probably going to have some anxiety that comes with this. And part of our role as a clinician is to support our client through their anxiety, excuse me, but also to support the family's anxiety that they might have as well. And doing things like making sure that we're checking on our own language and making sure that we're not using things that are using language that's polarizing, using things that are very binary. Because if you look in our societal roles, oftentimes when we're talking about things in general, not just when we're talking about LGBTQ care, but when we're talking about things in general, a lot of our language is very binary. It's very male, female. And that can have significant impact on our clients and what our clients are experiencing if we're continuing to use that language for ourselves. So making sure that we're breaking down some of that binary view with our own language, being cognizant of that in our own language, and then providing advocacy and providing psychoeducation for our clients. So in terms of physical transition in adolescence and what some of those things look like, we have things that are fully reversible, like puberty blockers. There is also treatment that is partially reversible, such as hormone therapy. But the things to be cognizant of when it comes to hormone therapy is that there is sometimes surgery that needs to be done to reverse it. Things like voice change aren't reversible. And if someone's not of legal age of 18, there's going to have to be parental consent involved. Things that are irreversible are going to be things like surgical procedures. So the minimum criteria for that is someone needs to be a legal adult, and that individual needs to have lived for at least 12 months in that specific gender role. So in terms of criteria for puberty suppressing hormones, providers are looking for intense gender dysphoria, things like puberty worsened gender dysphoria or led to the emergence or had a significant impact on the development of gender dysphoria. We're also addressing those coexisting mental health problems so that adolescents are stable, because, you know, as with any sort of mental health diagnosis, when we're undergoing treatment, when we're undergoing procedures like this, like there is a lot of question about a person's state of mind, a person's state of being, that can come from medical practitioners and providers. So making sure that we're addressing those coexisting conditions is also a very important part of providing quality care. Making sure that we have consent from the adolescent or consent from a parent or guardian. There's and the thing to keep in mind and the thing to consider is that, as I mentioned before, when you're referring to someone who it's not our place as providers to question what a client is experiencing. And so when we or another provider is doing something like withholding treatment is drawing a line in the sand, and it is letting someone know that that is not gender affirming care. So being cognizant of how much we are, again, using things like polarizing language, making sure that we're referring to other providers who aren't going to do things like withhold treatment, is an important part of our role as a mental health practitioner. So we've talked about children, we've talked about adolescents. Moving on to adults with gender dysphoria or folks who are gender nonconforming, things look a little bit different. So we still want to do the same sorts of assessment. We're still assessing for gender identity and dysphoria. We're also looking at the availability of support and what those social supports will look like in their family, or not just in their families, but in their social supports, and social peer and social relationships. We also want to make sure that gender issues aren't the secondary mental health concern, or that they may not be a symptom of another mental health diagnosis. So when we are referring for hormone therapy, when we are documenting that letter, we're making sure that we document personal history, treatment history, a client's progress, and their eligibility. So we'll look at example text once we've gone through all this. I'll give you an example. I'll show you an example letter of one that I've written in the past. But the whole idea is that we are making sure that we are writing out clear treatment history, clear treatment that we have gone through with this client, and that we're making sure that we're documenting that so that medical providers are able to see in black and white when they have the letter in front of them that this person is of sound mind and they are eligible to receive treatment. Whether this is the hormone therapy slide, but this is not just for hormone therapy. This goes across the board for hormone therapy and gender confirming surgery. And that last statement there, one of the reasons why I decided I wanted to do this presentation in the first place was because in terms of myself as a supervisor and in terms of other colleagues that I've met and known and so on, I've met and been in contact with a lot of folks who have had a lot of uncertainty about writing letters like this. Actually, one of my supervisees, specifically in our first meeting, when we were talking about starting supervision with one another, one of the things they said to me is, I want to write a lot of these letters. I want to be able to provide this type of care. Are you comfortable signing these? Are you comfortable with providing supervision for that? And without hesitation, I told them absolutely, but they had had a very hard time finding a supervisor that was willing to sign off on gender, like these referral letters for trans care. And I understand in terms of other colleagues that I've talked to in the past about it, there's a lot of concern about the liability, and that's often been the defining point where they said, no, I don't feel comfortable writing this because I don't want to be liable for this. Because what if somebody changes their mind? And I've written this letter that says that they're of sound mind and they make this decision. What if I get sued? In the land of getting sued, what if I get sued? And the truth of the matter is, like, it doesn't matter if we're writing things like this or if we're writing other letters. If that's the road clients want to go down, it's not going to be because we chose to write letters like this. It's not going to be because we're doing things like providing ethical quality care by providing referrals. It's going to be something else, almost always going to be something else. So making sure that we keep in mind that we share that burden with other providers that are working with folks is a way to sort of think about that general liability when it comes to making the referrals and providing that standard of care. So in terms of hormone therapy letters and the content that needs to go in those hormone therapy letters, we want to make sure we're identifying characteristics of the client, making sure that if we've done any sorts of assessments or used any assessment tools, excuse me, that we are including those results, making sure that we're documenting diagnoses, and making sure gender dysphoria is a diagnosis that we are documenting, as well as our length and relationship, or the length of our relationship and the type of relationship that we have with that client. And, you know, I know for myself and for supervisees, sometimes that is just an assessment, and sometimes that's 2 or 3 years. It's that is a conversation to have with your client or your potential client moving forward. Making sure that we're documenting the clinical rationale and why we support that client. Making sure that we're explaining the criteria have been met when we're writing, and that we've obtained informed consent, and that our willingness to coordinate is also documented as well. I think that is probably a really important piece, because coordination of care is going to be something that you're going to want to do throughout the transition process with folks. So that can be a phone call. That can be, I've provided email as well. But part of that is, you know, that advocacy piece as well, making sure that we are providing not only a standard of care, but quality care by coordinating services with other providers. So in terms of referral for surgery, 1 letter is needed for top surgery and 2 referrals are needed for genital surgery. In terms of surgery referral and content that needs to be in the letters, again, we're looking at identifying characteristics, psychological assessment and diagnosis, your relationship with the client, including the type of therapy that you've done with that client and what the interventions and outcomes have been with that client. Making sure you're documenting the clinical rationale for surgical procedures and that the criteria have been met, that you've received informed consent from your client, and again, that you're available for coordination of care. So in terms of the criteria between hormone therapy and referrals for surgery or surgical procedures, there's a little bit different criteria between these two. So for hormone therapy, you've got persistent gender dysphoria that's been well documented, making sure that that client is capable of providing informed consent and can make decisions for themselves, that they're at least 18, or making sure that we're following standard of care guidelines if they're younger, and that their other mental health conditions that they have been seeking treatment for are stable if there are other mental health conditions at play. In terms of criteria for top surgery, we need one referral that's, again, persistent and well-documented gender dysphoria, making sure that somebody has the ability to make decisions for themselves. And then when we're looking at bottom surgery, so genital surgery, there's 2 referrals needed. But there is also that requirement of 12 continuous months of hormone therapy on top of 12 continuous months of living as their gender that they are seeking surgical procedures for. And it's important to make sure that the standards of care, we know that the standards of care apply to everyone. Even those who might be living in institutional environments. So the current standards of care that we are going on and that we've been talking about are version 7. So there's been several sorts of revisions that have occurred throughout the years when it comes to providing ethical care, the standard of care. So the differences between previous versions and version 7, which was written in 2012, was there are new guidelines for binary defined surgery. There's also new guidelines and recommendations for preserving fertility. Just as I mentioned before, mothers are not the only people who give birth anymore, and making sure that we're not using polarizing language, and that we are providing, that medical providers are providing care that is preserving fertility, can be really important to a lot of folks. There's 2 referrals needed from mental health professionals, and then 18 is the minimum eligibility for any sort of genital surgery. It's hard for folks to meet the 2-letter criteria. And I think part of the reason that, at least what I have seen in my own clinical practice, part of the reason that folks have problems with the 2-letter criteria is because it's difficult to find folks who will write letters. So the fact that 2-letter criteria has to be met creates a barrier to care. It truly does. Creates a barrier to care. So the standard of needing to be a legal adult is up for debate. There's the idea that there's possible developmental delays or intellectual disability if you're unable to have sexual experiences that are that align with folks' gender identity when they're in adolescence. And then, you know, I think the bottom line here is that most of these services, when it comes to hormone therapy and surgical procedures for having gender confirmation surgery, it comes down to not wanting to provide those treatment options to anyone who's under the age of 18 for fear of the legalities, which we could have a whole conversation and debate about that. But the fact of the matter is, at this current point in time, it may change in the future, but at this current point in time, there are no surgical procedures that are conducted for folks under the age of 18. There are also other considerations when we're looking at insurance and insurance providers. So not every insurance will provide or will provide coverage for gender affirming procedures. There are a few that do. However, there are still barriers to care when it comes to the insurance. So one of those first things is that treatment needs to be documented as being medically necessary, whether that be experimental or cosmetic. There has to be medical. They want medical documentation that shows undergoing treatment is medically necessary for the client. There's also the idea that medical necessity is not necessarily addressed when we're looking at gender dysphoria. And this again leaves the insurance companies to sometimes make those decisions for themselves and to deem what is medically necessary and what might not be. So one of the things that is hopeful is that there are health insurances that have gotten rid of some of the exclusions that they had for trans care, but trans folks are still having a difficult time receiving care for various reasons. But again, it is creating a barrier to treatment. And I would say not only is it creating a barrier to general treatment, it is creating a barrier to critical treatment, to it is creating a barrier to very life-saving treatment. But in terms of insurance and the medical necessity, most insurance companies look at medical necessity as the physical and functional benefit of a procedure. So many of the insurance companies, either delay and denial, or folks experiencing delays and denials, can again create that barrier to care. So with insurance, if insurance is going to cover various treatments, There's 2 letters that are needed. Folks have to be at least 18 years of age. There has to be, again, the 12 continuous months of hormone therapy, 12 continuous months living as their gender. So it's stricter than the Wpath standards. And the other thing that we're running into is that insurance companies are often rejecting letters if the therapist doesn't have a PhD. That's not a Wpath requirement. That's an insurance requirement. So the important thing to keep in mind, and then again, we'll look at an example here so you can see an example text, is that when you're writing letters like this, keep it short, keep it simple, keep it as short and as brief and as simple as you can. Make sure that you're documenting the information that needs to be documented, and making sure you're extending that olive branch, and providing continuity of care between physicians, other clinicians that are providing care to your particular client. So this is a sort of general example of what a letter might look like or could look like for someone. This one is, again, going back to those standards of care. We have well documented gender dysphoria. We have identified the reasons why we have diagnosed gender dysphoria with that particular client. That the client is able to make fully informed decisions for themselves with regards to treatment. And that if there are any other behavioral health interventions that need to be done, that those are done. Also, that we've provided, this one has PHQ-9 and a GAD-7, so that the client has undergone a PHQ-9 and a GAD-7, and that we have medical documentation of that, and that we believe, based on our assessment of that client, based on my assessment of that client, that they are able to make decisions with regards to hormones, with regards to surgery for themselves. And then providing that outreach to for continuity of care, providing that outreach for continuity of care and coordination of services in the future. So we will now open it up to questions.
So there was only one question in the chat, which was, are you able to share your slides?
Yes, I can do that. Jenna, is there a way that we are doing like presentation shares like that?
Colleen?
Sure. I was just going to say, yes, we can send out presentation material with the attendance report if everyone's interested. Happy to do that.
Okay, awesome.
And yep, and all the recordings are going to be uploaded to our YouTube page, so I will include that link as well.
Okay, great.
Yep. Christina did have a note in the chat. Christina, you are welcome to come off mute, and if you want to expand on that note, I find it interesting as well.
I just put a mouthful of food in my mouth. So hold on, give me a second.
It's always the way, right?
Right, of course. So yeah, so it's interesting, right, that there's this cutoff that you have to be 18 to have any kind of, surgery, right? Gender surgery. But if a baby is born intersex, doctors will sometimes take it upon themselves to make the decision to do surgery or encourage parents to do surgery that is otherwise unnecessary. And of course, there have been cases where, false truths have been said, like, oh, this could, turn into cancer and things like that. But in some cases, it's just, oh, you don't want your child to be different or whatever. And these surgeries are done unnecessarily, before the child has any input or say in determining, their own bodily autonomy. And yet we put this other restriction on the other end. And it's just, I want to say interesting, but that's not the word, because it's just horrible,
Right. No, I think that's very valid. And even thinking about, and that's another like rabbit hole we could go down, as well as like the rabbit hole of circumcision and why we still do things like circumcision in the United States. And yet that like those are considered like medically necessary that we do on infants, but we're creating this restriction of care and lack of access to care by, making folks wait until they're 18 to undergo any sort of medical treatment. Any other questions or anything? Awesome. Okay. I'll take silence as a cue that there are none. Thank you all so much again for coming to this particular session. And like Colleen said, I'll make sure that Colleen gets these slides and they can be sent out to folks.
Thank you, everyone.